but we had to shuffle because of certain problems. So we start with breast cancer. Breast carcinoma is our topic, which is very important from the exam point of view. Unfortunately, there was one slide here which did not get downloaded. I don't know why. So if I ask you about the location, what are the quadrants? If I ask you about the quadrants, can you name the quadrants of the breast? Can you name all the quadrants of the breast? Yes, can you name the quadrants of the breast? Yes, tell me. Upper, outer. So, which is the most common location? If I just talk about the quadrant, if I just talk about the quadrants, which quadrant is most commonly involved? So, breast overlapping and unspecified, if you leave that, and if you just talk about the breast quadrant, the proper breast, and divide them on the basis of quadrants, and you are being asked by the examiner, which quadrant is most commonly involved, what would be your answer? The upper outer quadrant. The upper outer quadrant. The upper outer quadrant. Okay. Then you get the upper inner quadrant, lower outer quadrant, lower inner quadrant. Many are there. Then central portion of the breast, the axillary tail of Spence, or the axillary tail of the breast. So it can arise in any location of the breast, but the most common, if we divide it on the basis of the quadrants, the upper outer quadrant of the breast is most commonly involved. Now there was one picture, I don't know why it did not get downloaded. So if I divide breast carcinoma, so one is in situ and the other is invasive. One is in situ and the other one is invasive. So if we divide in situ, it's called LCIS and DCIS. So what is LCIS? What is DCIS? Lobar carcinoma in situ and ductal carcinoma in situ. I'm not sticking to this, but I'll be talking only on the breast carcinoma proper. So when we divide, I'll rather be talking on invasive carcinoma. So invasive carcinoma, the most common type is NST or NOS. What is it? This is the one that we will be discussing in details. Not otherwise specified. Okay, NOS is not otherwise specified, but what is NST? No specific type or no special type, whatever. Then you get, so this is basically ductal carcinoma. Then you get lobular carcinoma. You get medullary. Then you get mucinous, tubular. So these are various variants. Then there is spindle shaped. So our topic for today would be NST, not otherwise, no special type or not otherwise specified. And I'll be explaining a little about lobular carcinoma also. Read about the various types of invasive carcinoma, the various variants of invasive carcinoma in details. Okay, just for viva purpose, they may ask you the various types, but for exam purpose, NOS or NST can always come. Okay, so before we go into details of NST, of ductal carcinoma, what are the risk factors? Risk factors is something that you should know. The first, the ones on the left hand side are very essential. Age. When does it increase? When does it increase? Now, breast is one of the most common malignancies we get in women. Remember that. Breast is one of the most common malignancies we get in women, and if a woman lives for 90 years, she has a chance of surviving for 90 years or more, have 1 in one woman out of 8 have a chance of developing a breast malignancy. Now, breast malignancy is probably the most common malignancy arising from the skin appendage, because breast is a modified skin appendage, right? So, breast carcinoma is probably the most common skin appendage malignancy. Breast is one of the most common organ, or one of the organs which is very easily palpated. A woman can palpate it and feel for a lump. So like cervix, it can also be prevented. Even though cervix, you cannot palpate a malignancy in the cervix, but for a breast, in case of a breast, a woman can palpate and feel a lump and take interventions. But still, women die of breast malignancy. Many women develop breast malignancy and ultimately die of it. Why? কেন? No, metastasis তো পরে আসছে. Yes, metastasis to a certain extent, but why metastasis? In fact, there was a time after the invent of mammography, the number of breast cancers suddenly shoot up. Why? After the invent of mammography, all of a sudden, the statistics started to show that the number of malignancies have doubled. Before the advent of mammography, it was less, but after the advent of mammography, it started to double. Why? Sorry? Lymphatic? What has lymphatic drainage to do with mammography? What has radiation to do with mammography? What has radiation to do with mammography? See, before the advent of mammography, only the lesions which were palpable could be identified. But the moment mammography came into picture, the technique came into market, the small lesions, the radiodense lesions, or the lesions which present with just calcification without any palpable mass, they started to get detected. And that is the reason why, because small lesions which are not palpable started to get detected because of the development of mammography. Such lesions were included in that statistical study. So number of cases, cancer cases shoot up. You got it? It's not that before the advent of mammography, number of cancers were less. No, the number of cancers were not less. They were present. But they could not be identified. And after the invention of mammographic technique, because of the radiological advances, small lesions which are not palpable by hand, they started to get detected by the mammographic technique. And that is the reason why the number of breast carcinomas shoot up. Because there are many cancers, say less than 2 centimeter or less than 1 centimeter, which cannot be palpated. They present as radiodense masses, or they present as just calcifications. They are not palpable by hand. They started to get discovered by the mammography technique. And that is the reason why number of breast cancers shoot up. It's not that they were not present, they were present, but they were not discovered. You did not have the correct method, the correct technique to identify them. That is the reason. Okay, so coming to the risk factors, where do you get malignancies the most? Which age group? I have written 7th to 8th decade. Before that, I would compare to younger women do not get breast malignancies. Before 25, it's very rare to get a malignancy. But once the women start advancing, her age advances, that's when she gets malignancy. So 7th to 8th decade is the peak when women get maximum malignancy. But younger women, if younger women develops malignancy, they are more dreaded as compared to the elder ones. Then age at menarche, early menarche, like 11 versus 14, 14, 15 or 16, that's probably the age when the women will get into her menarche. But if she develops menarche before the age of 11 years, she is more predisposed to get malignancy. Age at first live birth. Age at first live birth. what has live birth to do, what has birth to do with age? Why multiparous women get more malignancy as compared to nulliparous women? Or why women who breastfeed more are less likely, not that they don't develop, but they are less likely to develop malignancy as compared to the ones who do not breastfeed or who less breastfeed? Lactational amenorrhea কি হতে পারে ওখানে?
ইস্ট্রোজেনটা কমছে তো তাই জন্য proliferation কমে যাবে।
Proliferation of what? Good answer, but what? So what happens? So malignancy কোথা থেকে arise করে? Breast there are two types of cells. One is the luminal cells, which produces the milk, and then you below the luminal cells, what do you get? The myoepithelial cells, which contracts. So the luminal cells are the one which produces maximum ductal carcinoma. So when a lady breastfeeds a child, this luminal cells goes into a stage of terminal differentiation. So they are removed from that pool of malignancy, and that is the reason why women who breastfeed her child or multiparous women develop, it's not that they don't, but when you compare with nulliparous women, multiparous women develop less breast cancer. Women who breastfeed a child more develops lesser breast cancer as compared to her counterpart who do not. Okay, so that is the reason. Then first degree relatives with breast cancers, there is a genetic correlation to it, and I'm going to come to that later because I'll be talking about the BRCA1, the BRCA1, BRCA2 genes. Okay, so first degree relatives means mother, sister, daughter. That is the first degree relatives. Coming to atypical hyperplasia. Atypical hyperplasia. Atypical hyperplasia means there are how many layers in breast? Maybe one layer of luminal cells and below it is a myoepithelial cell. But when there is hyperplasia, more than 3-4 layers, there's proliferation of the cells and they undergo, excuse me, and they undergo atypical changes. So atypical hyperplasia is a predisposing factor for malignancy. In biopsy, if we discover atypical hyperplasia, that is a signal, basically, a warrant signal. Take care or take interventions. Otherwise, this patient may progress into malignancy. Race. Non-Hispanic white women, I don't know why. Non-Hispanic white women, maybe it's just because of the genetic, various genetic makeups, non-Hispanic white women are more prone to develop breast malignancies as compared to the others. Then comes estrogen. What happens in estrogen? What does estrogen cause? Estrogen increases breast cancer or not? Yes or no? Yes. And if you add progesterone to it, the risk doubles. If you add progesterone to it, the risk doubles. Okay, that is why oophorectomy, women who undergo oophorectomy, they are less likely to get malignancies. Okay, so estrogen predisposes our women to develop malignancy, and if you add progesterone to it, the risk is doubled. Okay, breast density. Breast density, see, this breast density was the one I was talking about few minutes back. Breast density, with higher breast density, that is an indication that definitely you cannot say that it is malignant, but it can be malignant. Higher breast density goes more in favor of malignancy. And this higher breast density is identified by mammography. That is why I was telling you, sometimes women may not present with a definite palpable mass. They may present with a radiodense breast, and when the radiologist identifies our radiodense breast, he alerts the respective doctors. Okay, radiation exposure, and if the radiation exposure occurs at a very young age, why could a woman undergo radiation exposure? For example, radiation exposure in the chest in case of a Hodgkin's lymphoma. So if you receive a radiation exposure, it can predispose to malignancy. Carcinoma of the contralateral breast or endometrium. Geographic influence, not explaining much, depends on which country you belong to. Diet, yes, alcohol. Alcohol is one of those things which predisposes to breast malignancy. Obesity. What has obesity to do? Obese women develop breast malignancies more as compared to non-obese women. Exercise has what? Exercise has a good effect means it does not predispose to malignancy. Breastfeeding, as I have explained, if the lady breastfeeds the child more, lesser chance of developing malignancy. So these are not so important as compared to the ones which are on the left hand side. Then you get various environmental toxins, tobacco exposure, nicotine exposure and all. So these are all the risk factors, and examiner may ask you, I don't think you're going to get this question for exam, but examiner may ask you some of the risk factors which are associated with breast cancer. Now, can I go to the next slide? Yes or no? So, etiology and pathogenesis. There are two things you must remember. One is the genetic factor or hereditary factor, and the other is the sporadic factor. So, we will be talking about the genetic factor first. And in genetic factor, you must remember the name of these genes. Just in this slide, just remember the name of the genes. One is the genetic factor or hereditary factor, and then there are factors, the sporadic cases of breast carcinoma. So sporadic cases, I don't think they will ask you, but in genetic factors, hereditary factors, they may ask you the name of the genes. BRCA1, BRCA2, these two are very important. BRCA1 and BRCA2. Why? Why? BRCA1, yeah, tell me. You said something? Huh? No, nothing. It has nothing to do with the percentage. Why? Why BRCA1 and BRCA2 is given so much of importance? Because women with a germline mutation of BRCA1 and BRCA2, they are predisposed to develop ovarian carcinomas also. They can develop ovarian carcinomas also. Oosh. I don't know why the slides did not get downloaded. Something went wrong. You know, download hoy. Unfortunately, I can't show you the slides. So remember this, then you get the P53 gene, CHEK2 gene. So BRCA1 and BRCA2, sorry, some of the slides did not get downloaded. I don't know why. It has never happened with me. So BRCA1 and BRCA2, remember at least these two genes. Why they are essential? Because a woman with a BRCA1 and BRCA2 mutations, if proven, she can also undergo malignancies of the ovary. And why it is also given importance is one famous actor, I would rather say an actress. Yes, that's why. You know that. He knows it. You guys knew it? You guys knew it? So at least you will be able to remember BRCA1, BRCA2. Who underwent this oophorectomy and all those things? Which actress? Angelina Jolie. Yeah. So she did the genetic study and she had, the mutation was found and she removed everything, all her organs and all. So you know it, so at least you should be able to answer this question. BRCA1, that's why I've given importance to BRCA1 and BRCA2. Okay, no slides. So, shut up. Keep quiet. So, before I go to carcinoma, I'll just tell you I just told you DCIS and LCIS, they are in situ lesions. Just remember this picture, you don't have to study. Ductal carcinoma in situ and lobular carcinoma in situ. So, there is something called here, this is a necrosis which is known as comedonecrosis, which you get in DCIS. Okay, then you get the various patterns of growth like solid, papillary, cribriform, micropapillary, etc., etc. Just remember the name, not so important from your exam point of view, but examiner may ask you. You won't get it in theory, but definitely in Viva, examiner may ask you. So remember all this comedonecrosis, the various patterns of growth like the papillary, micropapillary, then solid, cribriform, etc., etc. And then just study a little on the Paget's disease of the breast. the Paget's disease of the breast, but I'll be talking more on invasive carcinoma. So this is the topic which you can get for exam, invasive carcinoma. So which is the most common invasive carcinoma? Which is the most common type of invasive carcinoma? Which one? Invasive carcinoma সবথেকে common variant কোনটা? 70 to 80%. Ductal carcinoma, NST, no special type. So if examiner asks you what are the various invasive carcinomas that you know, with which you are going to begin? If the examiner asks you what are the various invasive carcinomas that you know, which one are you going to start with? Huh? What ductal? Okay, NST. Not NOS, not otherwise specified by NST. So, breast malignancies most commonly present as palpable masses or mammographic densities. I have explained you what is a mammographic density. So, they may present either as a palpable mass or as a mammographic densities. And palpable masses, by the time they're discovered, 50% or more than 50% have already metastasized to the lymph nodes. So remember one thing, when it comes to prognosis, the size of the tumor is very important. The size of the tumor is very important to stage a tumor. Okay, so palpable tumors, by the time they become palpable, they have already grown. It's not that someone has implanted a tumor in the breast. The tumor was initially small and it started to grow in size. The woman, either she ignored it or she did not realize it, and by the time she realized it and it was palpable, and the reason she realized it was because there was a palpable lump in the breast, which turns out to be a malignant one, unfortunately. And by the time a lesion becomes big to be palpated, it has already 50% of it has already metastasized to the lymph node. And once metastasis takes place in the lymph nodes, the prognosis starts to become more and more dismal. Remember that. Okay, মানে বুঝেছো কথাটার মানে কি? Huh? If there is metastasis, the prognosis becomes poor. Okay. Now some of the tumors may be so big, they become fixed to the underlying skin with the help of Cooper's ligament. And they give the orange, the chest wall, they give the breast an appearance like the peel of an orange. Komla lebur khoshar moto. So that particular appearance is known as puri orange. Some of the tumors may be big enough to attach itself with the help of Cooper's ligament to the underlying skin, giving the appearance of a peel of an orange. That particular term is puri orange appearance. Okay. Sometimes the tumor may present as inflammatory carcinoma. What is inflammatory carcinoma? Sometimes the tumor cells may block a lymphatic. Hindering the flow of the lymph. So the patient presents with a painful erythematous breast. There may not be a palpable lump. You know why there may not be a palpable lump? Because these cells are discohesive. They do not form a lump, but rather single cells infiltrate the lymphatics, block the lymphatics, so the lymph flow, it hinders the flow of lymph, allows the lymph to accumulate, resulting in what? Resulting in obstruction of the lymph flow and erythematous swollen breast. They may not be a palpable lump straight away, but this patient presents with an inflammatory, painful erythematous breast. So that is inflammatory carcinoma, and the prognosis is very poor in such cases. Very, very, very guarded, very dismal. Prognosis is very poor. And some breasts may remain occult, which I have mentioned how. Some may present as just radiodense masses, while other may present as plain calcifications which are identified only on radiographic imaging. So these are all the presenting features of a breast carcinoma. পরীক্ষাতে এরকমই কোশ্চেন করবে, এইগুলোই পরীক্ষাতে কোশ্চেন করবে। ওকে, so the most common tumor is NST, which I have just mentioned. The most common tumor is NST, no specific type, or NOS, not otherwise specified. Grossly they present as firm or firm. Grossly they present as firm, and when you cut through it, it produces a grating sound. It produces a grating sound because of elastosis, or sometimes because of presence of calcifications in the breast. So they produce a grating sound when cut. They may have an irregular border. Very rarely they have a well circumscribed border. Most commonly they have a irregular border. They are firm in consistency with irregular border. Okay, and they produce a grating sound, which I just told you. Sometimes they may present with areas of necrosis and hemorrhage, depending on the stage when the tumor was discovered. Depending on the stage when the tumor was discovered, if it's an advanced stage, it may produce areas of necrosis and hemorrhage, but it's occasional. So grades of NST, we can divide it into well differentiated, moderately differentiated, and poorly differentiated. So we take into account three things. When we grade a tumor, or when we describe a tumor, we look for tubule formation. So how does a tubule look like? The more the tubular formation is, the better the tumor is differentiated. Why? Because tubules are normal constituent. So this is how tubules look like. Isn't it? These are the luminal cells, and here are the myoepithelial cells. So more the number of tubules you'll see in case of a malignancy, the better the differentiation is. So that is a well differentiated tumor. Say more than 90% tubule formation is a well differentiated tumor. Around 50% of tubule formation will be moderately differentiated tumors, and less than that, when the tumor infiltrate as solid sheets of cells, that's when we call it poorly differentiated tumor. And other than tubule formation, we take into account two more things. That is cellular pleomorphism. Obviously, the tumors with better differentiation, the cellular pleomorphism will be less as compared to the ones which are poorly differentiated. There will be maximum cellular pleomorphism in poorly differentiated tumor. There will be maximum cellular pleomorphism. And in between well and poorly differentiated tumor will be the moderately differentiated one. And the last one we take into account is mitotic count. More than 10 mitosis per 10 high power field, or mitotic count as in 10 high power field. So all these things together, they form a grading system, which is known as Scurf-Bloom-Richardson grading system. Scurf-Bloom. So we take into account tubule formation, then cellular pleomorphism, and then activity. So this triad, they form a grading system. They form a grading system. This is known as Scurf-Bloom This is known as Scurf-Bloom-Richardson grading system. Okay. So this is what I was talking about. Just know the names. Do not by heart it. You do not need it at your level. I'm just explaining it to you. Okay, just remember the names. Scarf, Bloom, Richardson grading system. If the examiner asks you, examiner will be more than happy to give you 75% number. And if he asks you, if he or she asks you, what are the criteria based on which you categorize a Scarf, Bloom, Richardson, what are the things that you look into? So you say tibial formation, cellular pleomorphism, and mitotic count. So this triad forms a grading system which is known as Scarf, Bloom, Richardson grading system. Okay. Then we have a molecular pathway. I'm not explaining it to you. Based on the genetic makeup, based on the genes, signature genes, we divide it into luminal A, luminal B, that is estrogen receptor, progesterone receptor, HER2/neu, estrogen receptor, progesterone receptor tumors. Why we call it ER/PR? Because estrogen receptor, progesterone receptor. What is the importance of knowing it? Such tumors will respond to hormonal therapy. Such tumors will respond to hormonal therapy. Then you get HER2/neu. HER2/neu. What? বুঝলাম না জানি না thank you I don't know, sorry. So the point is HER2/neu is basically a transmembrane protein, and against it antibody has been discovered or medicine has been discovered which is known as lapatinib or trastuzumab. So HER2/neu will not respond to hormonal therapy. You have to go for chemotherapy. So this is the importance of knowing these molecular things. Do not by heart it, just know the names. Luminal A, luminal B, which are ER positive, which are PR positive, or which are ER negative, PR negative, then HER2/neu positive, HER2/neu negative. That's all. Just know the names, okay? Then spread of breast cancer. What is a sentinel lymph node? What is a sentinel lymph node? Anybody? What is a sentinel lymph node? What is a sentinel lymph node? Anybody? Get up and answer. Yes. I'll pick up a random roll number and ask. Is that okay? Sure? No? Who wants to answer? Then someone raise the hand and answer. Even if you say it wrong, I don't mind. But even if you come out with the wrong answer, I can rectify it. What is a sentinel lymph node? And what is the importance of knowing a sentinel lymph node? Why should you do a sentinel lymph node biopsy in case of a breast cancer? Yes. Who wants to answer? Apollo. The first lymph node which is affected in a breast cancer. Okay, kind of okay, but add korte parle bhalo, good enough. What is the importance of knowing it now? Tell me. She has said, So if you, for example, now it's a proven case of breast carcinoma and you do a sentinel lymph node biopsy and it turns out to be negative. What are you going to do? Now it turns out to be negative. You do a sentinel lymph node biopsy, you put all those radio tracers and all, and you see that the biopsy is negative. The sentinel lymph node has not been involved. Yes, that means what? Not exactly that, but a good answer, good try. The thing is, if the first or second sentinel lymph node is negative, you can spare the patient of axillary dissection. You can spare the patient of morbidity. Means to the first or second lymph node ta jodi involved na hoy, then it's obvious that the rest of the lymph nodes are uninvolved. But if it is involved, then you have to do the entire block of lymph nodes has to be removed. That is the importance of doing a sentinel lymph node. First lymph node is unaffected, our lymph node orate hobe na. Simple. The patient is not safe, already the patient is in a morbid condition, but you can spare the patient of additional morbidity by not removing the other lymph nodes. But if it is positive, then you must remove the other lymph nodes. It may have spread to the other lymph nodes. That is the importance of doing a sentinel lymph node biopsy. And other than that, the spread of breast is just like other tumors, there is a local spread within the breast which can involve the skin, the fascia, the chest wall, etc. Then to the regional lymph nodes. Then hematogenous spread. So these are the methods of spread, which is very important. They won't be interested to know all these examiners. If I am the examiner, and I know many examiners who will never ask you all this, they are common, man. Regional, local, hematogenous. So neoplasia te porno hoye geche. Then they will ask you, what is a sentinel lymph node? What is a sentinel lymph node? A sentinel lymph node can come in neoplasia also. So what is a sentinel lymph node? Sentinel lymph node must be at your fingertips, and you have no excuse for not having known what is a sentinel lymph node. Okay, so I have given you, if you want, take the slide, read about the sentinel lymph node. It's very important. Prognostic and predictive factors, we can divide it into major and minor. So very important from your exam point of view. Major prognostic factors, definitely you have to know. Invasive versus in situ carcinoma, and you should be able to answer it. Which one has a bad prognosis? Invasive versus in situ, which one has a poorer prognosis? Invasive. Obvious. Okay. Then distant metastasis. Cancer doesn't kill a patient unless until it has metastasized. You know that neoplasia is a porno. So what kills a patient more is the metastasis. So if the tumor has metastasized, obviously it has a poorer prognosis as compared to ones which has not metastasized. Lymph node metastasis. I have just explained you sentinel lymph node. Tumor size. যতগুলো আজ পর্যন্ত আমরা ক্যান্সারে রিপোর্ট করেছি, breast carcinoma is the one where tumor size is of paramount importance. মানে স্টেজিং এর একটা ক্রাইটেরিয়া হচ্ছে TNM. Classification মধ্যে this T, the size of the tumor কিন্তু very essential. Okay. Locally advanced disease. Obviously, the ones which has advanced locally has a poorer prognosis. And finally comes inflammatory carcinoma. What is an inflammatory carcinoma? What is an inflammatory carcinoma? Lymph node obstruction hoye jacche. Inflammatory carcinoma has a very poor prognosis. So at least these are the major prognostic factors, and you must remember all of them: invasive versus in situ, distant metastasis, local spread, lymph node metastasis, tumor size, locally advanced disease, and inflammatory carcinoma. Then comes the minor factors. Histologic subtype. Histologic subtype, NST, generally have a bad prognosis as compared to others. Medullary carcinoma has a poor prognosis. Histologic grade, grade 1, grade 2, grade 3. Grade 1 versus grade 2 versus grade 3. Which one has better prognosis? Grade 1 has better prognosis, grade 2 has the poorest prognosis. And what do you do to look for the grade? What is the grading system called? Huh? Fried rice. What did you say? Pyrad. তুই অনেক কিছু জানিস। Pyrads না এটা না। আরে লিখে রেখেছি ওখানে আমি। Scurf Bloom Richardson. Okay. Then the ERPR status. The importance of knowing ERPR status is estrogen receptor, progesterone receptor. These tumors which are ERPR positive will respond to hormonal therapy as compared to HER2-neu. HER2-neu will never respond to hormonal therapy. You have to go for chemotherapy for such patients. These are all the factors which come into play. Then there is lymphovascular invasion. Obviously, the one with lymphovascular invasion will have a poorer prognosis. Higher the proliferation rate, poorer is the prognosis, because there will be more mitosis, more cellular proliferation. Then DNA content. So major factors and minor factors, these are the ones which you have to remember. Coming to the lab diagnosis, triple assessment. Clinical examination, keep quiet, this is the last slide maybe. Then you get the imaging, and then you get the pathological. So clinical examination, you know how a clinical examination, you have seen maybe in the OPD, how breast examination is done, palpation and all. So when you do palpation, and if you find a palpable mass in the breast, what is the next thing that the clinician will tell you to do? ask her to lift the hands and palpate the axillary lymph nodes to see if there is any palpable lymph nodes or not. And if there are palpable lymph nodes, most likely it can be a malignancy, it can be something else also. Without ancillary tests, you cannot come to a conclusion. But it can happen that if there is a very hard lump, painless lump, and it's growing in size, and the patient has discovered it, say, maybe 1 or 2 years back, and patient has not taken proper intervention, let the tumor grow, and then she complains that initially I had a lump in the breast, and then I started to develop lump in the right axilla. Every possibility of malignancy is there. And so when you develop, as a pathologist, when we get a lump in the breast, when we get a definite lump, the first and foremost thing we do is, after we do physical examination of the lump, we ask the patient to lift her hands and palpate for all the axillary lymph node, at least the axilla. We don't know where the axillary lymph node is, but we palpate the axilla and look for any lump is there or not. So if any lump is present, along with the, during the FNAC of the breast lump, we do an FNAC of the axillary lump also. Okay, that's how it is. That's how it should be done. Then comes imaging. Ultrasonography, mammography. I've just explained you the mammography, the radiodense lesions, the calcifications and all. And then we go for pathology. Fine needle aspiration cytology. Remember, at least you can remember this, at least this diagram so you can remember. Na? If you present this, you will get more than 70% marks. Examiner will be happy. You won't have so much time to read what you've written inside. So, confident diagnosis can be achieved in 95% of cases. Confident diagnosis can be achieved in 95% of cases. So, this is what I have been telling you. Clinical history, history of lump, onset, rate of growth, pain, nipple discharge, any bone pain, etc. and all. Then clinical examination, look for skin, nipple retraction, skin dimpling, look in the nipple and areola, eczema, pudgy orange appearance, axillary lymph node status, all these things. Just write, just remember the name. And then you go for mammography. Then you go for mammography, densities. Malignancies are radiologically denser. Malignancies are radiologically denser as compared to the normal intermingled breast tissue. Malignancies are radiologically denser. And what is the most importance of what is the importance of doing a mammography? It's important cancers. Okay, which I have explained. Some breast cancers just present as radiodense masses, without any palpable mass, and that's where mammography, the importance of mammography comes into play. It helps to identify the small breast lesions or the small breast malignancies. Then comes calcification. Calcification means deposition of calcium salts. It can happen, you know what calcification is. It has been taught in the first chapter. So, this is the last slide, and then you get the ultrasonography. The most important thing, the most important function of ultrasonography is it distinguishes between solid and cystic lesions. It distinguishes between solid and cystic lesions. Then comes MRI, magnetic resonance imaging, is useful to see if there is any chest wall invasion or not. Then comes nipple discharge, FNAC and biopsy. Nipple discharge, sometimes the patient can present with, what can be the cause of nipple discharge? If it's a young woman and there's a nipple discharge, milky, what is it? Galactorrhea. Galactorrheas generally are not malignant, but bloody discharges, I won't say that bloody discharges are malignant, but bloody discharges are definitely alarming. Whereas white discharge, milky discharges are more in favor of a benign breast disease, for example, a benign cystic disease or a galactorrhea, which is commonly seen in young lactating women. Bloody breast disease, blood oozing out of the nipples, definitely raises a concern that can go towards malignancy. Bloody nipple discharge can go towards malignancy, whereas milky white, I won't say that it is malignant, but it certainly is alarming. It certainly is alarming. Then comes FNAC. You know how, have you seen a FNAC? Have you seen how FNAC is done? Come to Central Lab someday, I'll show you how FNAC is done. Very simple. or some of you become a subject, I'll just inject a needle just like that, take some normal cell out, and I'll show you how FNAC is done. Huh? The subject hobby? Hobby? Very simple, FNAC. And finally, if FNAC is proven to be positive, FNAC 99% cases are positive, though there are false positive and false negative cases, we go for biopsy and histopathological examination. If I ever get a biopsy, breast cancer, I'll call you guys, I'll show you how we take biopsy. We take all the margins, we take the tumor proper, then we look for the axillary lymph nodes. All lymph nodes we find, we have to take biopsy from them and submit it for histopathological examination, because everything is important. TNM, N stands for node, lymph node. T is tumor, N stands for node. So we need to know the nodal status. And then finally comes M. M stands for metastasis. M stands for metastasis. So this finishes your topic on, now you have a class at 4 o'clock, right? You get 10 minutes. Go, have a cup of tea and come back.
All of you have this logbook? Do you have this logbook? Yes. Have you started writing? Have you started writing? Why not? কেন? বুঝতে পারছি না। লেখা আছে তো কি লিখতে হবে? এর মধ্যে লেখা আছে, ঠিক আছে। আমি তোমরা আমাকে অনেকেই বলেছো যে স্যার লগবুক সম্বন্ধে আমাদের একটু ক্লাসের দরকার। এটা হচ্ছে ফার্স্ট ক্লাস, পেজ নাম্বার 41। পেজ নাম্বার 41, that is the experimental pharmacology, and I have arranged some more classes about your logbook. That is the practical classes oriented only for how to write logbook. So after that, you have to finish your logbook within 15th of January or preferably within December. Now coming to this topic, that is the experimental pharmacology. Now what do you mean by experimental pharmacology? What do we mean by experimental pharmacology? That it means that the effect, depiction or demonstration of the effect of some drugs on animal. It is a vivid, real type experiment. Why? To find out suitable agent for a human being. And what we see in experimental pharmacology, that is number one, efficacy, and then toxicity. That is, these two are the most important part for which we have to undergo testing of the drugs in animals. And have you, I think you have got knowledge how the new drug being evaluated. When an agent has been found out of possessing some important effect, the drug is not directly administered to the human being. Before that, you have to go through screening of these drugs on certain animals. And mechanism and efficacy, mechanism and site of action, and also the toxicity. Why it is being included in UG curriculum? And it is a more or less monotonous study before, I think, before 1980s or like this. It is only the theoretical part of teaching, where you have to read the books and to listen to only the lectures. After that, this curriculum has been included in the pharmacology discipline, and at that time, real experimentation was done. That is, experimentation of different drugs on autonomic pharmacology as well as in certain gastric pharmacology. But there, nowadays, you won't find anywhere the experimentation on animals only for teaching purpose. Why? You know, number one, the most part of the ethical issue. The sacrificing animal for purpose of only teaching has been banned. And secondly, there are certain obstacles in this experimental pharmacology. As of I am telling you some points. If you are to demonstrate the effect of drugs on blood pressure, and it is done on either on cat or on dog, and experiment started suppose that 9 a.m. it will, and the actual procedure or after experiment actually started at about 2 to 3 p.m. It is a long time, long duration of experiment, and after that you are not sure you can have the actual result out of that. So 6 hours effort may be failed, you are not sure. That is the most important part. So that's why later on we are thinking how to overcome these obstacles. How? That is the computer simulation of experiment. What is that? It is the certain programmed package of different disciplines, not only in medical teaching but also in other disciplines. You can have this computer simulation teaching like this. তোমাদের কি হলো কি? তোমার কি হয়েছে কি? হ্যাঁ। So that is known as the computer assisted learning. এর সুবিধা কি কি আছে? আমরা যেমন the drawbacks in actual real time experiments, আমরা long time procedure, অনেকক্ষণ সময় লাগে. Out of that, we are not sure that we are having the actual result or like that. But this can, you are definite that there will be result. And moreover, তোমাদের অ্যানাটমিতে এখনো আছে যখন ডিসেকশন হয় কজন দেখতে পাও? এখন তো সবাই দেখতে পায় এখন, কিন্তু তোমরা আগে ছিল কি তোমাদের যখন করা হতো এই সামনে 6-7 জন দেখতে পায়, তার পেছনে টুলের উপর দাঁড়িয়ে থাকতে হতো, এরকম আর কি। সেরকম এক্সপেরিমেন্টাল ফার্মাকোলজিতে একটা জায়গায় হচ্ছে কজন দেখতে পাবে? 7-8-9 জন 10 জন, কিন্তু with the aid of CAL, everyone will be helped by this method. So everyone can see that this experimentation. So this is why that is being included. Now, can I use any animal? No. Why? Number one, handling. Handling of animal is very important. And number two, efficacy. We are going to, during evaluation of new drug, we are going to administer that drug on the human being. So we have to test it on the animals where the result will be much more closer to that of human being. Third is calculation. Dosage calculation. There are some procedures. Suppose 1 milligram drug has been administered to one animal. So there is some methods by which we can extrapolate the drugs on the human being. So these are the advantages. These are some common examples, most important and widely used are the mouse. Then rat, albino rats, then guinea pig. So this guinea pig, you can see that docile, susceptible, isolated tissues are used mainly for, that is the ileum, vas deferens, uterus, tracheal chain. So these are meant for evaluation of bronchodilator drugs and for immunologically active drugs. So that's why different types of animals are being used. Rabbit, cat, dog and mouse. Next is suppose we have to start experiments on guinea pig ileum. It is not that you just cut the that is the ileum and take it to any solution and you can judge the experiment. It is not that. There are some physiological salt solution, there is some composition, definite composition by which the tissue will be survived for some hours. These are the disadvantages of real-time experimentation with the use of animals. So it is a computer-based package to provide interactive instruction and usually in a specified subject area, that is CAL. Computer model of a real or theoretical experiment system that contains information mimic the actual experimental setup in a laboratory. Experimentation can take place, that is changing the input of to the model or that affects the output. Pressure agent, that is a blood pressure raising drug. Isoprenalin, blood pressure raising drug. Noradrenaline. Any other? Adrenaline. Now, what is the effect of adrenaline on blood pressure? Suppose now here we are using adrenaline. What will be the type of curve? What type? That curve is known as the is it monophasic or biphasic? Biphasic. Why it is called biphasic? Blood pressure, after rising of the blood pressure, it comes down below the baseline, then it comes to the normal level. Why? What is the mechanism? What is the mechanism of rising of blood pressure after? How adrenaline causes rise in blood pressure? Bolo ki positive inotropic, positive chronotropic effect. What is the receptor involved? No alpha. Positive inotropic. What is the use of alpha receptor for inotropic effect? It is a beta 1 effect. So positive inotropic, positive chronotropic by beta 1 receptor. The blood pressure additional component of adrenaline by which it will help to raise the blood pressure. That is the alpha receptor. That is a vasoconstriction. In which bed? কোথায় হয় vasoconstriction? সব জায়গাতেই হয়। কোথায়? Skin, mucosa, renal and splanchnic. So vasoconstriction. So this is the mechanism for rise of blood pressure after adrenaline. As the time goes, the concentration of adrenaline comes down, and on that, when the concentration is much low, receptor action will be prominent. কেন এই যে fall in the baseline, below the baseline কেন পাচ্ছি? Fall below the baseline কেন পাচ্ছি? So what? There will be alpha receptor, there is beta 1 receptor still. It is not that. Beta 2 receptors are more sensitive to the circulating epinephrine or adrenaline. These are the stock questions in the oral. Why you are getting the biphasic response? Why there is fall below the baseline? Still, as there are still alpha receptor, alpha 1 receptor, beta 1 receptor. But in lower concentration, beta 2 receptors are more sensitive than the alpha and beta 1. Another experiment, if you administer a very low dose of adrenaline, what will you see? There will be no pressure effect because the concentration is much lower. And as we know that in lower concentration, that is the beta 2 receptors are more sensitive than the alpha 1 and beta 1. And at that time, we are only getting the vasodepressor effect. So this is how the adrenaline causes rise in blood pressure. Now, how these actions are being terminated? এই অ্যাকশনটা কি করে চলে যায়? মানে অ্যাড্রিনালিন কনসেন্ট্রেশন ব্লাডে কমে কি করে? কি বলো ম্যাডাম? কি মেটাবলিজম বলো? লিভারে আমাদের বডিতে যে অ্যাড্রিনালিন বেরোচ্ছে, এন্ডোজেনাস অ্যাড্রিনালিন, how it is being terminated. মাও একটা মনে আছে একটা রিআপটেক so endogenously released adrenaline the concentration at the neuroeffector organ will be diminished by reuptake maximum will be reuptaken by the nerve ending, that is the reuptake 1. So that is the main mechanism in the degradation of the endogenously liberated adrenaline, and after that there is a dissociation of the adrenaline from the nerve ending to the surrounding tissue. But if we administer adrenaline from outside, then the metabolism, that is mainly the COMT in liver, that is the main source by which the exogenously administered adrenaline will be degraded. Now we can what will be the effect that can be seen here. এখান থেকে হবে না ফোন দিচ্ছি। Here you can see that is the dog, one dog that is being anesthetized, and there is a femoral venous cannulation being done. It is anesthetized by chloralose, and then the femoral vein will be cannulated for administration of different drugs, and after that this carotid artery is being exposed and it is cannulated and connected to the mercury manometer, by which we can record the blood pressure. Now you can see that is the epinephrine will be administered in the dose of 2 microgram per kg. So I am injecting epinephrine. Can you see that biphasic response of adrenaline? Biphasic response of adrenaline. Now if we increase the dose, you can see that the effect will be increased. Now next is the noradrenaline. What is the effect of noradrenaline on blood pressure? Only BP বাড়বে তো adrenaline দিলে তো BP বাড়ছে। So what is the difference between the adrenaline and noradrenaline? What is the difference between the action of adrenaline on noradrenaline on blood pressure? BP কমবে? তুমি এখানে আইসিইউ সেটআপে গেছো কোনোদিন? যাবে, গিয়ে দেখবে কি ইউজ হয়, কোন ড্রাগটা ইউজ হয় প্রেশার রেজ করার জন্য, দ্যাট ইজ দ্য নরএপিনেফ্রিন। তার কি ডিফারেন্সটা কি? ইট ইজ অনলি দ্য রাইজ ইন ব্লাড প্রেশার। কেন? That is only the rise in blood pressure, and the rise will be much more than that of adrenaline. Rise will be much more than that of adrenaline. Can what is the mechanism? Alpha 1 and beta 1 effect. Now tell me, what will be the effect on heart rate with adrenaline? ওটা কোনো ভেগ অ্যান্সার না, আমি বলছি হোয়াট ইজ দ্য এফেক্ট অফ অ্যাড্রেনালিন অন হার্ট রেট ডিক্রিজ। আর কে বলবে? এই ইন্টারন্যাশনাল হাইয়েস্ট কে পেয়েছে? ইন্টারন্যাশনাল হাইয়েস্ট কে পেয়েছে? বলবে না, কেউ দাঁড়াবে না, কেউ পায়নি হাইয়েস্ট। নো ওয়ান হ্যাজ গট দ্য হাইয়েস্ট মার্কস ইন ইন্টারন্যাশনাল। হার্ট রেট কি হবে? হার্ট রেট এই যে অ্যাড্রেনালিন দিলে হার্ট বাড়লো, এবার হার্ট we can measure the heart rate. Two important things are there. One is the chronotropic effect, by which the heart rate will be increased. Okay, chronotropic effect by which the heart rate will be increased. On the other hand, what will happen at the height of rise in blood pressure? baroreceptor mechanism. কি স্টিমুলেটেড হয়? ভেগাল স্টিমুলেশন। ভেগাল স্টিমুলেশন কি হলে হার্ট রেট কি হবে? নেমে যাবে। তাহলে দুটো জিনিস অপোজিট by chronotropic effect, but there is fall below the baseline. তার মানে কি ডায়াস্টোলিক প্রেশারটা কমে যায়, ডায়াস্টোলিক প্রেশারটা কমে যায় উইথ অ্যাড্রিনালিন। আর এই হার্ট রেট অথচ ভেগাল স্টিমুলেশন ডিপেন্ডস অন হুইচ ফ্যাক্টর? Vagal stimulation is dependent on which parameter? There are, one is the blood pressure, one is the pulse pressure, one is the mean arterial blood pressure. কোনটার উপর ডিপেন্ড করে baroreceptor stimulation বেশি হবে না কম হবে? mean arterial blood pressure. অ্যাড্রিনালিনে কি হয়? baseline অল্প বাড়লো আর the mean arterial blood pressure not much raised, will not be much raised. So the vagal stimulation will be prominent here because the mean arterial blood pressure is not much changed after administration of adrenaline. That's why there will be the more decrease in the heart rate. So increase in the heart rate. ভেগাল স্টিমুলেশন জন্য আরো একটু কমবে হার্ট রেট উইথ অ্যাড্রিনালিন। ভেগাল স্টিমুলেশনে এখানে যদি 1 হয় 3 হচ্ছে, so there will be reduction in the heart, it is with the noradrenaline, but with adrenaline there will be fall in blood pressure. Due to fall in blood pressure the heart rate will be increased, তাই তো? হার্ট রেট বাড়লে পরে ব্লাড প্রেশার বাড়লে পরে আমার একটু হয়ে গেছে, ভুলে গেছে, আমার হার্ট রেট বাড়লে decreased, but as there is fall in blood pressure below the baseline এখানে বেশি হয়, তখন কি হয়? reflex tachycardia, and plus there is beta 1 effect, increased chronotropic effect, that will also do increase in the heart rate. So at the height of blood pressure there will be heart rate will be decreased due to baroreceptor stimulation, but due to fall below the baseline there will be reflex tachycardia as well as positive chronotropic effect. So the heart rate, overall heart rate will be increased with adrenaline. But in case of noradrenaline, we don't have any beta 2 receptor effect, that is no fall in blood pressure, that is no diastolic fall in blood pressure, only the pressure effect. That's why with the stimulation of the baroreceptor mechanism the heart rate will be reduced much more with noradrenaline. Here we can also receptor mechanism, heart rate will be decreased. So that is why we can judge if you are given one copy of tracing of blood pressure, both either in case of adrenaline or noradrenaline, we may not get this beta 2 effect. Judge how we can tell whether the blood pressure effect is due to either adrenaline or noradrenaline by recording the heart rate. ঠিক আছে? Now we are administering norepinephrine. Sorry. Again. You can see that there is blood pressure, there is only rise in blood pressure, no fall below the baseline. So that is the ideal recording of blood pressure after administration of noradrenaline. এখানে কেন baroreceptor stimulationটা বেশি হয়? Because the mean arterial blood pressure will be changed much more. This is the baseline. Systolic blood pressure will be much more raised because the strong alpha 1 action, systolic blood pressure will be raised much more, but there is no fall below the baseline. That means the mean arterial blood pressure will be increased much more. That's why we are getting the strong norepinephrine, and the heart rate will be decreased. That is the reflex bradycardia. Now, can you name one vasodepressor drug from autonomic pharmacology, that is a sympathomimetic? Any sympathomimetic drug can you name which will cause fall in blood pressure? Beta 2 agonist. নাম বলো। বিটা 2 অ্যাগনিস্ট দিলে শুধু অতটা ফলে না, আমি তোমাকে স্পেসিফিক জিজ্ঞেস করিনি। What are the classical adrenergic drugs? Noradrenaline, adrenaline, isoprenaline. And out of these three, name the drug which can cause fall in blood pressure. আবার মিথাইল ডোপা বলছে এখানটায়। মিথাইল ডোপা কি অ্যাগনিস্ট? Isoprenaline. What is isoprenaline? What is the effect of isoprenaline? It is a non-specific beta stimulation, non-specific beta stimulator, isoprenaline. As we said that the beta 2 receptors are more sensitive, for that we are only getting the beta 2 stimulatory action. If there is beta 2 stimulation, what will happen? There is fall in blood pressure. Now we can see that the fall in blood pressure with isoprenaline. It is a strong non-selective beta agonist. That means it has got both beta 1 and beta 2 effect. Now tell me, what will be the effect on heart rate with isoprenaline? What will be the effect of isoprenaline on heart rate? কি হবে? ঠিক আছে, তুমি একটা বললে যে বিটা 1 যেহেতু নন সিলেক্টিভ বিটা স্টিমুল্যান্ট, বিটা 1 স্টিমুল্যান্ট অ্যাকশন উইল কজ পজিটিভ ক্লোনোট্রপিক এফেক্ট। আর কি কিছু বলবে? এই রেসপন্সটা দেখো না, it is not the rise in blood pressure, it is only the fall in blood pressure. So there will be reflex tachycardia. তার মানে beta 1 receptor stimulation, chronotropic effect, and due to fall in blood pressure there will be reflex tachycardia. So there will be much more increase in heart rate with isoprenaline. আগে অনেকদিন আগে হার্ট স্ট্রোকের সময় এটা দেওয়া হতো। Some fall in blood pressure as it is blocking the alpha 1 receptor. Now after some time what I have administered? Repeating the dose of epinephrine. Now what we can see, is there any rise in blood pressure? Is there any rise in blood pressure? ওটা ওটা কি বললাম এইমাত্র, কি বললাম এইমাত্র, শোনোনি কেন? ওয়াই আর ইউ ইন দ্য ক্লাস? হ্যাঁ, চেষ্টা করছো কেন? তোমার কি মনে হয় না এটা জানলে পরে তোমার সুবিধা হবে পরীক্ষার সময়? I have administered the epinephrine. There is rise in blood pressure. Then after that, I have injected phentolamine. What is phentolamine? What is phentolamine? What is phentolamine? Alpha blocker. So there is some fall in blood pressure. After that, I am repeating the dose of adrenaline. What you can see? কি হয়েছে? What you can see, what is the effect of this use of first dose of epinephrine on blood pressure? কি হয়েছে? বেড়েছে না কমেছে? আবার কোথায় প্রথমে এখানে কি আবার কিছু হয়েছে নাকি? এখানে দেওয়ার সঙ্গে সঙ্গে কি হয়েছে? ফল করেছে। তো আমরা তো জানি যে এপিনেফ্রিন দিলে পরে ইনিশিয়ালি রাইজ করে, এখানে ফল করলো কেন? ইনভার্সন অফ ভেসোমোটর রিভার্সাল মানে বুঝলাম না। রিভার্সন অফ ভাসোমোটর রিভার্সাল না, এটা হচ্ছে ভাসোমোটর রিভার্সাল অফ ডেল। হোয়াট ইজ কল্ড ডেল? সায়েন্টিস্ট যিনি এটা দেখেছিলেন সেজন্য ভাসোমোটর রিভার্সাল অফ ডেল। As we have blocked the alpha receptor, so there will be only beta and beta 1 and beta 2. And as we know, the beta 2 receptors are more sensitive than the beta 1 receptor. That's why we are getting only the fall in blood pressure. So that is known as the vasomotor reversal of Dell. How can we reverse the effect? How can we reverse the effect? Beta blocker. That means if we use epinephrine, after that if I use beta blocker, then alpha blocker, but then we can see that there will be no effect. There will be no effect. That is known as the reversal of vasomotor reversal of Dell. ঠিক আছে, শোনো একটু, আমার লাভ হবে না, তোমারই লাভ হবে, আমার কোনো ক্ষতি হবে না। এবার these are the adrenergic drug. Now coming to the cholinergic drug. What is the prototype of, what is the name of the prototype drug of cholinergic system? তোমরা কেউ বলবে না। What is the name of prototype cholinergic drug? আয়ুষ কোথায়? আয়ুষ, আয়ুষ আছে? আয়ুষ নেই, বাহ, কি বলো? What is the name of prototype? Prototype কথাটা মানে জানো? What do you mean by prototype agent? What is the meaning of prototype agent? Huh? Different form. না, কে বলতে পারবে what is the meaning of prototype agent? In one group there are so many drugs, and the first drug which has been isolated and which has got the most of the effects of all drugs of the same group, we pick up one drug. That is known as the prototype drug of that group. It is not possible to demonstrate or describe the effects of all the drugs of the same group. It is the time is very minimum. That's why one typical drug has been identified. In case of adrenergic drug, adrenaline or epinephrine is the prototype drug, and in case of cholinergic system, what will be the prototype drug? জানো না তুমি? তুমি তোমরা কি যখন পড়ানো হয়েছে তখন কি আজ বোঝনি না পড়নি? কোনটা ঠিক? কোনটা ঠিক? হ্যাঁ, তোমাকে কি জিজ্ঞেস করেছি আমি? আমি তোমার মতো দু চারজন ছাত্রের জন্য আমি বদার করি না। তোমরা যদি আমরা নাও পড়াই তোমরা বাড়িতে পড়ে নেবে, আমাদের মেইন কনসার্ন হচ্ছে ভাস্ট রেস্ট অফ দ্য স্টুডেন্টস। কি কোলিনার্জিক ড্রাগ, হ্যাঁ বলো বলো বলো, বলছো তো অ্যাসিটাইল কোলিন। তো নেম আদার কোলিনার্জিক ড্রাগস। What are the different types of cholinergic drug? First of all, that is known as the cholinester. Acetylcholine, আর কি? Cholinesters, name the cholinesters. One is the acetylcholine. Then carbachol, bethanecol. আর কি আছে? Cholinester ছাড়া আর কি আছে? Cholinomimetic alkaloid. নাম কি? আমি কি জিজ্ঞেস করছি, তুমি শোনো। কোলিনোমাইমেটিক অ্যালকালয়েড, হ্যাঁ নাম কি? না, অ্যালকালয়েড ইজ আ ন্যাচারাল ড্রাগ। নিওস্টেমিন ইজ নট দ্য ন্যাচারাল ড্রাগ, ইট ইজ আ সিনথেটিক ড্রাগ। মাস্কারিন, আমি তো মাস্কারিনের কথা বলিনি তো। কোলিনোমাইমেটিক অ্যালকালয়েড, পাইলোকার্পিন। তারপরে হচ্ছে তোমার কোলিনেস্টারেজ inhibitor or anticholinesterase. So many drugs are there, of which one is the natural physostigmine, and all other rest are synthetic drugs. Now, what will be the effect of acetylcholine on blood pressure? কি হবে? ডিক্রিজ হবে, কমবে। কেন? কোন রিসেপ্টর মেডিয়েটেড অ্যাকশন? M1, M2 or M3? M2। আর কে কি বলবে? মেইনলি যদিও 5টা রিসেপ্টর আছে এম, কিন্তু মেইনলি 3টে আমরা কনসিডার করি, কারণ তাদের অ্যাকশন আছে, M1, M2, M3। তো এই 3টের মধ্যে কোন রিসেপ্টরের জন্য অ্যাসিটাইলকোলিন দিলে পরে ফল ইন ব্লাড প্রেশার হবে? M2 আর M2। তুমি কি মানে ঝাঁকের কই নাকি? M2 কেন? হার্টে যদি করে নেগেটিভ আইনোট্রপিক এফেক্ট। তো অ্যাসিটাইলকোলিন দিলে পরে ফলটা কেমন হয়? এই নর্মাল, এই এতখানি নামলো, এই উঠলো। শুধু M2 ব্লক করলে পরে এত শার্প ফল ইন ব্লাড প্রেশার হবে না। শুধু M2 দিলে পরে এত শার্প ফল ইন ব্লাড প্রেশার হবে না। এই ফলকে কি টাইপ অফ ফল বলে? এই যে শার্প ফল অ্যান্ড র্যাপিড রিটার্নিং টু দ্য বেসাল লেভেল, এটাই কি টাইপ অফ ফল বলে? Evanescent fall in blood pressure. Evanescent fall in blood pressure with acetylcholine. এটা কেন পাওয়া যায় বলছি দাঁড়াও। কোশ্চেনটা কি লেখা আছে দেখো তার সঙ্গে সঙ্গে। The action of acetylcholine is evanescent. Why? এই যে দেখো, sharp fall in blood pressure and rapid rise to the normal basal level, এটিকে বলা হচ্ছে evanescent fall in blood pressure। এরকম ফল আর কোথায় পেতে পারো? হিস্টামিন and also with isoprenaline। তাহলে এখানে M2 রিসেপ্টর দিলে পরে এতটা ব্লক করলে এতটা শর্ট ফল ইন ব্লাড প্রেশার হবে না। তো হোয়াট ইজ দ্য এফেক্ট ইফ ইউ স্টিমুলেট দ্য M3 রিসেপ্টর? কি হয়? M3 রিসেপ্টরকে স্টিমুলেট করলে পরে কোথায় আছে M3 রিসেপ্টর? M3 রিসেপ্টর কোথায় আছে? গ্ল্যান্ডে আছে। আর স্মুথ মাসল কোথায় কোথায় আছে? আই আছে। আর কোথায় আছে? হ্যাঁ, ব্লাড ভেসেলে যদি স্মুথ মাসল থাকে, সেখানে যদি M3 রিসেপ্টরকে স্টিমুলেট করি তাহলে কি হবে? আরে বাবা, M3 রিসেপ্টরকে স্টিমুলেট করলাম, দ্য রিসেপ্টর প্রেজেন্ট ইন দ্য ব্লাড ভেসেল উইল বি স্টিমুলেটেড। কি হবে? কোলিনার্জিক স্টিমুলেশনের জন্য ভেসেল কনস্ট্রিকশন হবে। কি জিআই কেন? তুমি তো বললে ব্লাড ভেসেল। The blood vessel এর উপর যদি M3 receptor stimulated হয়, there will be fall in blood pressure. So we are getting evanescent fall. Number 1, M2 receptor blockade, negative inotropic, negative chronotropic effect. But the more important effect is on the M3 receptor stimulation. So that will cause sharp vasodilatation. So resulting evanescent fall in blood pressure. দেখো হিস্টামিন দিলে পরেও র্যাপিড ইভানিসেন্ট ফল ইন ব্লাড প্রেশার হয়। কোন রিসেপ্টর? H1 রিসেপ্টরের ব্লকের স্টিমুলেশনের জন্য। সো প্রেশার এফেক্ট দুটো, এপিনেফ্রিন, নর এপিনেফ্রিন। আর ডিপ্রেশার এফেক্ট, ডিপ্রেশার ড্রাগ কী কী হতে পারে? একটা অ্যাডেনার্জিক সিস্টেমের জন্য আইসোপ্রেনালিন, কোলিনার্জিকের জন্য যে কোনো কোলিনার্জিক ড্রাগ, বাট দ্য মেইনলি অ্যাসিটাইলকোলিন, অ্যান্ড we can also get this type of vasodipressor action due to histamine. এগুলো ভুলবে না, এগুলো কিন্তু পরীক্ষা জিজ্ঞেস করবে। এমনকি তোমাদের যে স্টেশন থাকবে সেখানেও এরকম একটা কার্ড দিয়ে তোমাকে জিজ্ঞেস করবে, হোয়াট ইজ দ্য টাইপ অফ ফল ইন ব্লাড প্রেশার ইভানিসেন্ট, হোয়াট ইজ দ্য নেম দ্য এজেন্ট অ্যান্ড মেকানিজম উইথ ব্রিফ মেকানিজম। কোশ্চেনটা এরকমভাবে থাকবে। আর তোমাদের খাতা বলেছি না 41 পেজ বার করো। যাদের আছে 41 বার করো। প্রথমে হচ্ছে, এটা পরে বলবো, কাল বলবো। প্রথমটা এই যে 43 এফেক্ট অফ প্রেসার এজেন্টস। Effect of pressure agents। আজকে ডেট দেবে এখানটায়, এই যে draw the following graphs or charts or paste output from cal experiments illustrating the effect of drugs on blood pressure in an anesthetized animal। আজকে ডেট দেবে effect of pressure agents, দেবে কি কি? অ্যাড্রেনালিন, নরঅ্যাড্রেনালিন। effect of pressure agents অ্যাড্রেনালিন and নরঅ্যাড্রেনালিন দিয়ে কার্ডটা আঁকবে। তারপরে নিচে দেখা হচ্ছে এফেক্ট অফ ডিপ্রেসার এজেন্ট, আইসোপ্রেনালিন, অ্যাসিটাইলকোলিন, হিস্টামিন। এফেক্ট অফ এ ব্লকার, আমরা দেখাবো বিটা ব্লকার দিলে পরে ব্লাড প্রেশার ফল করবে। লিখবে এটা, ডেলস ভাসোমোটর রিভার্সাল অফ ডেল। ইউ হ্যাভ টু রাইট দ্যাট কার্ভ, ইউ হ্যাভ টু ড্র দ্য কার্ভ অ্যান্ড ইউ হ্যাভ টু ডেমনস্ট্রেট দ্য এফেক্টস। You have to write here what do you mean by vasomotor reversal of del, and this is one. Tachyphylaxis. What do you mean by tachyphylaxis? What do you mean by tachyphylaxis? কি হলো, কেউ জানো না? What is tachyphylaxis? তোমাদের টলারেন্স মনে আছে? বলো, হ্যাঁ বলো, জোরে বলো। র্যাপিড ডেভেলপমেন্ট অফ টলারেন্স। হ্যাঁ, আরো ভালোভাবে বলো। ঠিক আছে, আমরা কি করে পাবো ওটা? র্যাপিড ডেভেলপমেন্ট অফ টলারেন্স মানে কি? এজেন্টের যা এফেক্ট আমার ওটা তাড়াতাড়ি তার এফেক্ট চলে যাচ্ছে, সেটাতে র্যাপিড ডেভেলপমেন্ট অফ টলারেন্স। কী করে হয় এটা? শর্ট ইন্টারভ্যালে আমি যদি ওই ইন কুইক সাকসেশন ইফ দ্য ড্রাগ হ্যাজ বিং অ্যাডমিনিস্টার্ড দেয়ার উইল বি মাচ মোর ডিক্রিজ ইন দ্য এফেক্ট। সো দ্যাট ইজ নোন অ্যাজ দ্য tachyphylaxis. That is known as the tachyphylaxis. That is one type of tolerance, that is the acute development of tolerance. দেখে এখানে দেখানো যায় কিনা tachyphylaxis। এখানে হবে না, বিটা ব্লকার দিয়ে দিচ্ছি তখন হবে না। কি দিয়া? Name one adrenergic drug which is an ideal example of, which can cause an ideal example of tachyphylaxis. Name one adrenergic drug which is an ideal example of demonstration of tachyphylaxis. Tolerance, তুমি আজকে দিলে, কাল দিলে, 3 দিন পর থেকে তার রেসপন্স কমতে আরম্ভ করলো। বলো, অ্যাড্রেনালিন ড্রাগ কত রকমের হয়? ডাইরেক্টলি অ্যাক্টিং, আর কি হয়? ইনডাইরেক্টলি অ্যাক্টিং, আর একটা থার্ড ওয়ান কি? Adrenergic drug, classification of adrenergic drug. One is the directly acting, that is the adrenaline, norepinephrine, isoprenaline. Other is the indirectly acting, amphetamine and all those. and third group is the mixed acting. That means which has got the both direct, which is both directly acting as well as the indirectly acting. That is known as the mixed acting adrenergic drug. Name that. Tyramine to indirectly acting. Tyramine, huh? বলো 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 আর ভুল বলতে কোনো ভুল বলবেই বলো সে ড্রাগটা আগে এক সময় ইউজ হতো ব্রঙ্কিয়াল অ্যাজমায়, খুব ম্যাজিক ড্রাগ ছিল, কিন্তু তারপরে এই ট্যাকিফাইল্যাক্সিস আর ট্যাকিকার্ডিয়ার জন্য ওই ড্রাগটার ইউজ হয় না। হিস্টামিন অ্যাড্রিনালিন ড্রাগ তোমরা যখন বলবে তখন চিন্তা করবে কি বলছি আমি, হিস্টামিন কেন বলবো, আমি তো বলছি অ্যাড্রিনালিন ড্রাগ। জানা আছে? এফেড্রিন মনে আছে? হ্যাঁ, না বললে কি করে হবে, আমি বললে তারপরে বেরোবে। এফেড্রিন ইজ দ্য আইডিয়াল এক্সাম্পল অফ ড্রাগ কজিং ট্যাকিফাইল্যাক্সিস। So there is rapid successive decrease in the effect of ephedrine on blood pressure, that is known as the tachyphylaxis. And you have to know that the mechanism of development of tachyphylaxis. জানতে হবে এটা। এখানে দেওয়া আছে tachyphylaxis এজেন্ট এফেড্রিন। কি হয় লিখতে হবে। Ephedrine will cause rise in blood pressure, but if we use ephedrine successively, there will be diminution of effect, vasopressor effect of ephedrine. So that is known as the tachyphylaxis or acute tolerance. Next is the nicotinic action of acetylcholine. Acetylcholine has got two types of effect. One is the muscarinic effect, another is the nicotinic effect. By the muscarinic action, it will cause fall in blood pressure. And what is the effect of stimulation of nicotinic receptor on blood pressure? কি হবে? কি হবে? এই মোবাইলে কি দেখছিস তুই? না মানে? What is the nicotinic action of acetylcholine? কি হয়? What is the nicotinic action of acetylcholine? Muscle contraction. Nicotine কোথায় আছে? NN receptor, not NM receptor. Nicotinic receptor may be of two types. One is the NN, that is the neuronal type of nicotinic receptor, and another is the NM, that is the, আমি তো তোমাকে NM দিয়ে তো ব্লাড প্রেশার হবে না, ওটা তো মাসলের কাজ, তাহলে তুমি NM বলবে কেন? Now what is the effect of stimulation of NN receptor? কি হয়? কি হয় চিন্তা কর, বল। আমি ততক্ষণ গ্যাংলিয়নকে স্টিমুলেট করলে কি হবে? গ্যাংলিয়নকে ব্লক করলে কি হবে? ব্লাড প্রেশার কমে যাবে। তাহলে স্টিমুলেট করলে কি হবে? তাহলে নিকোটিনিক অ্যাকশন অফ অ্যাসিটাইলকোলিন ইজ রাইজ ইন দ্য ব্লাড প্রেশার। এত চিন্তা করতে হলে মুশকিল তো। So there is fall in blood pressure. So how can you block the muscarinic receptor? How can we block the muscarinic receptor? By giving. How can we block the muscarinic receptor? কি অবস্থা, আর 2 মাস 3 মাস পরে ক্লোনিডিন, তোমার মাথা না গাঁটটা মারবে আমি। ক্লোনিডিন এটা অ্যাড্রিনার্জিক ড্রাগ, তার সাথে সে মাসকারিনিক রিসেপ্টরের সাথে ইন্টারঅ্যাক্ট করবে। মানে নন স্পেসিফিক মাসকারিনিক ব্লকার, হাইলি পোটেন্ট ড্রাগ কোনটা? কি হ্যাঁ, কে বলছিল? কে বললো? অ্যাট্রোপিন। এগুলো না জানলে, এগুলো তো বেসিক, মানে বেসিক কনসেপ্ট, এগুলো না জানলে কিন্তু পরীক্ষা পাশ করতে পারবে না। মাসকারিনিক অ্যান্টাগনিস্ট যদি বলতে না পারো পরীক্ষা কিন্তু পাশ করবে না। এক কথায় বলতে হবে, নেম অফ দ্য মাসকারিনিক অ্যান্টাগনিস্ট, স্যার অ্যাট্রোপিন, আই নো দ্যাট অ্যাট্রোপিন, বলেই চুপ করে থাকবে। তারপরে যদি জিজ্ঞেস করে এটা কোনটা ব্লক করে, M1, M2 না M3, তখন তুমি বলবে যে স্যার এটা তিনটেই ব্লক করে, M1, M2 অ্যান্ড M3। তারপরে এখান থেকে আসতে পারে, তুমি M1 রিসেপ্টর ব্লকারের নাম জানো? হ্যাঁ স্যার জানি স্যার। কি? পাইরেনজেপিন, M2 এরকম আর কি। সো ইফ উই অ্যাডমিনিস্টার atropine after acetylcholine, let's see what will happen. There is no effect. Atropine has got no itself has got no effect. There might be little rise or little fall, might be, but usually there will be no effect of atropine on blood pressure. Now we are administering the same dose of acetylcholine again. এখানে কিছুই দেখাচ্ছে না, এটা ঠিকমতো হলো না, এটা হওয়ার কথা ছিল না, এটা আমরা আগেরটা যাই। এটা দেখাচ্ছে না ঠিক মতো। কি হবে? Rise in blood pressure. So that is the demonstration of nicotinic effect of acetylcholine, demonstration of nicotinic action of acetylcholine. How can we demonstrate? First, we have to use acetylcholine in the dose of 2 to 3 microgram per kg. Then, followed by, then we have to administer non-specific strong muscarinic antagonist, that is atropine. It is a blocker. After 5 what we have to wait. We have to wait because all the receptors should be blocked. So it will take some time. After that, if you are repeating the initial dose of acetylcholine, so instead of fall in blood pressure acetylcholine, we will get rise in blood pressure. So that is known as the demonstration of nicotinic action of acetylcholine. তাহলে লাস্ট পার্টটা হচ্ছে নিকোটিনিক অ্যাকশন অফ অ্যাসিটাইলকোলিন। ঠিক আছে, এটা যে 43 গেল, যে আইসোলেটেড টিস্যু, তার আগে আমি বলেছি যে লাস্ট পার্টটা, fill up the following table on the basis of rabbit eye experiment. Rabbit eye experiment on rabbit eye, meiosis or mydriasis. What is the effect of adrenergic drug or cholinergic drug on eye? Either it will be meiosis, that is the constriction of the pinpoint people, or dilatation of the pupil. So that's why the ideal animal used is the rabbit. But rabbit is a very docile, কারো বাড়িতে আছে rabbit? আছে? তোমার কাছে ছিল? খুব docile animal. একে করতে হয় কি, একটা rabbit box আছে, সেই বক্সে গিয়ে ওর মাথাটাকে ঢুকিয়ে দিয়ে আটকাতে হয়। কিন্তু ওই মাথাটা ঢোকাতে গেলে তুমি যে এরকম করে ঢুকে আটকাও না, তারপরে rabbit আর বাঁচবে না, মরে যাবে। সুতরাং it is a very docile animal. এই এটা কিন্তু লিখে রাখবে, ওই পেছনের পাতায় দেখো, ওখানে দেখো টেবিল আছে, পেছনে দেখো টেবিল আছে, মেজার, এই দেখো, এই লগ বুকে দেখো পেজ নাম্বার 44, পেজ নাম্বার 44 লাস্ট, আই এফেক্ট অফ ড্রাগস অন আই। এখানে দেখো লেখা আছে এজেন্ট, পিপল ডায়ামিটার, লাইট রিফ্লেক্স, কর্নিয়াল রিফ্লেক্স, intraocular pressure, other effects, that is the lacrimation or like this, and lastly remarks. আমি বলে দিচ্ছি, এগুলো তোমাদের ফিল আপ করে এটাকে কমপ্লিট করতে হবে। And there might be two types of effect. One is the light reflex, effect on light reflex, effect on corneal reflex, effect of light reflex, effect on corneal reflex, and intraocular measurement of the intraocular pressure. আর কি? পিপলের ডায়ামিটার। এইটা আমরা এই কটা আমরা দেখব। Now you can measure the pupillary diameter from this. Just approximate, you can write how much. It is the millimeter. It will be 1, 2, 3, 4 millimeter like this. 4 millimeter diameter. In normal, the diameter is 4 millimeter. লিখে রাখো, অন্য খাতা লিখে রাখো, before administration of drug, the normal pupillary diameter is 4 millimeter. Now we are administering epinephrine. You can see that epinephrine. এই যে আমরা ওষুধ দিচ্ছি, এটা কি হলো? Pupillary diameter is being increased. কত হলো? After administration of epinephrine, the diameter will be 1, 2, 3, 4, 5, 6, at least 7 millimeter. 7 millimeter. So there is mydriasis with epinephrine. এবার আমরা কি দেখব? লাইট রিফ্লেক্স কি হবে? লাইট রিফ্লেক্স কি হবে? নো রেসপন্স। এটা হচ্ছে নর্মাল, এটা রাইট আই। দেখো, constriction of the pupil. Light reflex present in the normal eye, but light reflex is lost in the epinephrine instilled left eye. How can we measure the corneal reflex? কি করে বুঝতে পারি corneal reflex? Corneal reflex মানে কি? Blinking of the eye. How can it be measured? By administration of touching of the cotton wool to the cornea. দেখেছো নর্মাল আইতে এখানেও আছে। So corneal reflex is present in both the eye with epinephrine. That means corneal reflex is maintained with epinephrine. IOP এখানে মেজার করার ব্যবস্থা নেই, মেজার করা যায়, it will be decreased. তোমরা যা লিখবে intraocular pressure is decrease, little fall in intraocular pressure, বাকিটা তোমরা লিখে নেবে। এরপরে হচ্ছে এবার আমরা দেখি অ্যাট্রোপিন। এটাতে হবে না, কেন অলরেডি ইট ইজ আন্ডার দ্য ইনফ্লুয়েন্স অফ এপিনেফ্রিন। সো উই হ্যাভ টু অ্যাডমিনিস্টার ড্রাগ অন রাইট আই। Atropine, there is dilatation of the pupil. সাইজটা তোমরা লিখবে নর্মালি যেটা 5 ছিল এটাও সেই 7-8 মিলিমিটার হয়েছে, ডায়ামিটার বেড়ে গেছে। মিড্রিয়াসিস উইথ অ্যাট্রোপিন। অ্যাট্রোপিন দিলে কি হবে? লাইট রিফ্লেক্স। lost. Present in the normal eye where the no drug has been administered. So atropine will cause abolition of the light reflex, mydriasis, and slight increase in the intraocular pressure. Slight increase in the intraocular pressure, and corneal reflex is maintained with atropine. Corneal reflex is maintained with atropine. বাকিগুলো আমি দিচ্ছি না, এরপরে শুধু তোমরা বাকিগুলো তোমরা লিখে নেবে যা যা আছে এখানটায়। কি কি হতে পারে? এফেড্রিন দিতে পারি, ফাইসোস্টিগমিন দিতে পারি। এবার আমরা দিব হচ্ছে লিগনোকেইন, দ্যাট ইজ লোকাল অ্যানাস্থেটিক। এই তাকাও, রাইট আইতে আমি লোকাল অ্যানাস্থেটিক দিয়েছি, রাইট আইতে লোকাল অ্যানাস্থেটিক দিয়েছি। এবার আমরা দেখব হচ্ছে দেখো রাইট আইতে আগে কি ছিল? corneal reflex was present but it is lost with local anesthetic. So how can we differentiate the agent whether it is local anesthetic or mydriatic? By observing the effect that is the on corneal reflex, on corneal reflex. ডায়ামিটার তুমি এটাতে কিছু হবে না তো, কর্নিয়াল রিফ্লেক্স আনচেঞ্জ সেম। ফাইসোস্টিগমিনে কি হবে? Contraction initially is few, after the followed by stoppage of heart at what? Systole or diastole?
সিস্টোলে
কেন বললে সিস্টল?
সেখানে কন্ট্রাক্ট
ওখানে তাকিয়ে দেখো, কেন সিস্টল বললে? বলো না, আমি আরেকটা দেখাচ্ছি, দেখো কি হলো? হার্ট স্টপ অ্যাট সিস্টল আর ডায়াস্টল? ডায়াস্টল। নাও আইডেন্টিফাই দ্য এজেন্ট। এক জায়গায় হার্ট রেট ইনক্রিজ, কন্ট্রাকশন ইনক্রিজ, বাট দ্যার ইজ স্টপেজ অফ হার্ট অ্যাট সিস্টল, ওপরে গিয়ে সিস্টল থেমে গেল। আর একটা হচ্ছে হার্ট রেট কমলো কিন্তু হার্ট উইল স্টপ অ্যাট ডায়াস্টল, নিচে। কোনটা কি বলো, তাহলে বুঝবো, তোমরা সব বুঝেছো, তাহলে আমি ছেড়ে দেবো। Potassium chloride, very good. Potassium is the inhibitory electrolyte or agent that will cause stoppage of the bradycardia followed by stoppage of the heart at diastole. Whereas calcium is the stimulatory drug. It will increase the contraction and heart rate, but followed by stoppage of heart at the systole. So that is how we can identify what is the agent, whether it is calcium or potassium. Okay, thank you.